Okay, so we're going to start talking about the ABCs of EMS: airway, breathing, and circulation. Okay, we're going to start with opening of the airway. All right. When we're actually working on opening of the airway is very important to us, guys. We need to be able to maintain it. And again, the only way that you guys can ensure that your patient is able to keep their airway open is if they are able to swallow. That's how you guys know that it is open and patent. Okay. This needs to happen pretty quick, okay? Just because somebody is talking to you, just because somebody is answering your questions appropriately, doesn't necessarily mean that their airway is patent. They could be drooling. They could be bleeding from their mouth. They could have a partial airway obstruction with vomit or food particles or maybe a toy or something like that. If we're dealing with a kiddo. All right, we're going to talk about patient positions and which one of those are actually the most effective for our patients. So specifically with our unconscious patients, the most common airway obstruction is the actual tongue itself. Okay, we're going to talk about patient positioning and how to make sure that if the patient is unconscious, on how to actually position their head with both medical and trauma, because we have to think about cervical precautions, your cervical spine. We don't want to damage anything. That's something, or we if it is damaged, we don't want to make it worse, right? So remember that the most common airway obstruction is the tongue itself. Okay, guys. So besides the tongue, some other common airway obstructions are dentures or false teeth. At this point in your guys' career, at the basic level, I'm going to tell you guys that if your patient does have dentures, we need to try to remove them as best as possible. Don't break them, they're expensive, okay? But make sure we're handling them correctly and make sure that we try to remove the dentures if possible. Once you guys move up to paramedicine, we're going to put a caveat onto that. But for now, at the basic level, make sure you guys are removing the dentures so that if we do accidentally chip one or break one, it doesn't fall on the back of the airway, in which we have to now go fish for it, okay? So just remove the dentures. Blood, vomiting, vomitus, emesis, okay? Any kind of vomit, any kind of mucus, right? Food and other foreign objects. And trust me, guys, you'll be amazed at some of the stuff that you guys will find in some people's airways. Okay, so the first maneuver that we're going to cover is what's called the head tilt chin lift maneuver. Okay, your patient needs to be laying flat for this, so they have to be supine on the ground. Remember, supine is when they're laying on their back. All right, this maneuver is great. Okay, and it's basically you kind of push down, push their head back on their forehead, and elevate their jaw. All right, this is the best way, the easiest way to position the patient's airway. This is specifically great for people that happen to be snoring if they're unconscious. Just doing a little head tilt chin lift can go a long way. And you guys do have a video of this in your lab show, so make sure you guys are looking at this. However, this is for patients that we are not suspecting any kind of cervical spine trauma. We are manipulating the spine on this. Okay, guys? We cannot... I don't care what it is. If you guys think if it's a fall, if it's a car accident, if you guys feel the back of their neck and you might feel the actual spine step off, or maybe they have bruising along their neck or something, we have to consider some kind of underlying injury, all right? If we are suspecting trauma whatsoever to the neck, we cannot do this maneuver. I'm going to repeat that. If we are suspecting any kind of cervical trauma, we cannot perform this maneuver, because if that spinal column or those vertebrae are fractured in that patient's neck and we move it, we can cause some more serious damage. And that's a great way for you guys to lose your license. I'm not going to spend too much time. Again, you guys do have a video of this in your lab show. Okay, so what do you do if we are suspecting somebody with a cervical spine injury or some kind of trauma to the neck? We're going to use something called the jaw thrust maneuver, okay? Basically, we're going to be by the patient's head. We're going to place our fingers, our thumbs, right at their jawbone, okay? Right at their jawbone, the back of their jawbone. So right where kind of towards the ears. We're going to put our thumbs there, and we're actually going to lift up with our thumbs in order to displace the actual tongue off the back of the throat. Okay, so we're going to put your fingers behind the actual angles of the lower jaw. We're going to move the jaw upward and use the thumbs basically to help keep or maintain this position. The problem with this position is that unfortunately somebody has to sit there and hold this, so you guys will lose a set of hands when it comes down to this position. Sometimes we need those hands, right? So we're gonna talk about airway adjuncts that you guys are going to be using in this class in order to free up your hands. But again, jaw thrust maneuver is the maneuver that we use if we are suspecting cervical trauma injuries, and you do have a video of this in your lab shell. Check it out. Okay, so once you have either performed the jaw thrust maneuver or the head tilt chin lift, okay, once you guys have actually manually opened up the patient's airway, we want to look at the chest and we want to observe for movement. We want to see if we're seeing that equal bilateral chest rise. We want to listen to see if we have stopped the snoring or any kind of adventitious sounds. We want to be able to look down the airway to make sure that there's nothing else occluding the airway. So yes, this actually requires you guys to open up the patient's mouth and look down it to see if you guys can actually see something. Okay, so we need to open up the patient's mouth. We need to look in the airway, okay? You guys can perform this head tilt chin lift. You guys can perform this jaw thrust maneuver, and the patient's mouth can remain closed. Open it. Look down the airway. The way that we do it is the cross finger technique, okay? And you guys can read through this. You guys will be able to practice this once you guys get your mannequins, and I'll make sure you guys practice this once you guys get your airway mannequins. Okay, but basically what this is doing is avoiding putting our fingers into somebody's mouth. Okay, the last thing you want to do is put your fingers in somebody's mouth. All right, because if somebody is faking, right, they could bite your finger off. Or even worse, if you go to open that patient's mouth and we really don't know what's going on with this unresponsive patient, and we put our fingers in their mouth to try to open up the airway, and all of a sudden they start having a seizure, you've just lost your finger. Okay, we want to try to avoid putting our fingers in patient's mouth as best as possible, and we'll talk about this more. I believe Andrew covers this in the video as far as the progressive airway video or the head tilt chin lift or jaw thrust, whichever video it is, but we will be discussing this in lab so that you guys can actually see how it's done. Okay, so for suctioning, we need to keep that airway clear. We want to make sure that nothing's in the airway, specifically if we are providing positive pressure ventilations via the BVM or the bag valve mask to our patients, okay? Just because you have opened up the airway doesn't necessarily mean that it is still secure. Specifically, again, with our unresponsive patients, they can vomit on you, right? And we are putting these people supine in order to help protect their airway. And of course, if that patient does start to vomit, or we got blood coming out, or if they're just drooling too much, eventually that fluid's going to start making its way down the trachea and enter the lungs, and we just cause an aspirated pneumonia, making our patient worse than they were when we met them. So we want to try to prevent that. There are numerous different kinds of portable suction units. You guys do have a portable suction unit on each ambulance. You guys also have a wall-mounted suction unit in the ambulance as well. The portable suction unit that we use most is like the picture on the right. It's that little red box. It is a unit that we can take on scene with us, right? They do have some pretty decent suction, guys, okay? We want to talk about suctioning as well, as far as how long to suction. Basically, you don't want to suction for longer than 10 to 15 seconds on each patient, right? So we're going to insert the actual what we call the Yankuer. It's spelled Y-A-N-K-U-E-R. The Yankuer is the actual stiff tip that we actually insert into the mouth. We want to insert the Yankuer as far down as we can see. We don't want to go past the part where we can't see it anymore. As far down as we can see, we want to suction for 10 to 15 seconds, and then we want to pull it out, okay? We can go back in and do it again, but we don't want to just sit there and suction and suction and suction and suction and suction, because sometimes those things are so powerful that you can actually deflate the lungs, okay? So we want to suction, just for a little bit. Try to get as much stuff as we can get out. Take it back out, give the patient a second, go back in and suction some more, okay? We do have plastic suction catheters, such as the Yankee Hour, which I just spelled for you guys. We do also have specific suctioning tools that we use for when we actually do drop one of our supraglottic airways. It's kind of a real flexible straw that we can actually insert into our supraglottic airway, the actual invasive airway that we're dropping into our patient's throat, and we can suction out that way. And we will talk about that more once we get into the actual airways that you guys can drop, and you guys should have a skills video on that as well in your lab. Okay guys, I did skip ahead just a couple slides. Again, I think this is the most important part with the knowledge that you guys need to know with suctioning. Either way, you guys can also suction the patient's nose, but if you're doing the mouth or the nose, don't do it for more than 15 seconds. 10 seconds for children and 5 seconds for adults. And again, we can actually suck the air out of the patient. Suction can result in hypoxia, which is lack of oxygen in the body. Okay guys, so we do have some tools in our kit in order to help with securing the airway, and those are what we call our basic airway adjuncts. And basically this is to prevent the tongue from sliding down into the back of the throat and occluding our airway for us, right? We have something called oropharyngeal airways, or what we call OPAs, oropharyngeal airways. All right, these are actually something that you are going to insert into the patient's mouth. Again, you guys have a skills video for this, so you guys can see how it's performed. And basically, it's a very rigid plastic piece of equipment that just basically kind of holds the tongue, pushes the tongue forward, and creates an airway for us in order to us to be able to maintain the patient's airway. It also will help us suction better with the oropharynx. Okay. Some of the indications that we're going to see for this is any unresponsive patient without a gag reflex. Okay. So how do we check for a gag reflex? Well, really, if your patient is not responsive to pain as far as your AVPU scale, right? You guys might be able to do a sternum rub on your patient. If they don't flinch with that pain, more than likely they probably don't have a gag reflex. However, we do something called the eye flutter test. So your patient's laying supine. You guys just want to kind of very lightly brush up against their eyelashes. If they flinch, it's a natural reaction for a person to flinch. If they flinch, they have a gag reflex. Okay. Now, not every patient flinches. Okay. There can be people that have an intact gag reflex, and they don't flinch when you touch their eyelashes. Okay. So that being said, the true only way to find out if the patient has a gag reflex is by you, unfortunately, sticking this halfway into their oral pharynx before you drop it all the way in and see if they gag on it. So when you guys are doing your OPA, or your oropharyngeal airway, make sure you guys do have suction ready, and make sure that you guys are ready to roll their patient onto the side just in case they do end up vomiting on you. Okay. This also helps with ventilations when you guys are doing when you guys are giving respirations or ventilations through the bag valve mask. It really helps kind of hold that airway open for you so that we can lift that tongue off the back of the throat. Some contraindications for this is for conscious patients. If they have a gag reflex, we can't drop this device, okay? Anybody who has an intact gag reflex, we can't drop this device, all right? When we're talking about nasal pharyngeal airways, also known as NPAs, nasopharyngeal airways, this can be anybody that is unresponsive or even an altered LOC. And guys, really, I can drop an NPA on all of you guys right now. It might not be comfortable for you guys because I'm inserting a tube into your nose. That tube's going to go all the way back into your nasal pharynx, all the way down into your oral pharynx, and it's going to help push the tongue forward in order to create an airway. But it can be done. You guys can Google nasal pharyngeal airway insertions, and you guys will see people actually doing it onto themselves. I've done it to myself. It's not really that bad, but make sure that you guys are also watching your skills videos on how to actually perform this procedure, so that you guys know how to actually do it. All right. Indications for the nasopharyngeal airway: anytime somebody is semi-conscious or unconscious or completely alert, but they do have an intact airway. They do have an intact gag reflex. Okay, so you can use this with somebody that does have a gag as well. It's not going to make them gag. It's just not going to feel too comfortable. All right. Contraindications is anytime that we are suspecting some kind of nasal injury. If we think that their nose may be broken, we can't use this. Okay, really any kind of facial trauma, we can't use this device. Okay, we want to make sure that this device goes down into the actual airway itself. And sometimes when we have a broken nose, or we might have damaged somebody's hard palates or something like that, we can actually insert this into the patient's sinuses, and that's bad. Right? We don't want to do that. We don't want to be tickling their brain with the tip of the NPA. So go ahead and Google nasopharyngeal airways. There's all kinds of videos on this, on people doing it to themselves, and techniques as well. But you guys do have the skills video as well, to help you guys see how to actually drop one of these.